I'm Dr. Rikiho. I am an internal medicine geriatrics doctor at Mount Sinai. I'm completing my residency and will go on to further training in geriatrics, which is specialty in the care of older adults. Today, we will be talking about respiratory illness in older adults. First, I just want to talk about who older adults are. Older adults are considered to be people who are 65 years or older. Older adults in general are at higher risk for respiratory illness, and this is a kind of fancier term for any kind of disease or illness state that is due to a process in the lungs and the other airways. The reason that older adults are at higher risk are essentially twofold. First, the immune system does not work as well as we age. It's just not as strong as when we're younger. And then older adults are also more likely to have different health conditions, whether that's diabetes, high blood pressure, strokes, etc. So the combination of a weaker immune system and having multiple health conditions comes together and essentially increases the risk for developing different lung conditions. And not only are you more likely to develop lung conditions, you're more likely to have more serious sequelae or complications of them. The good news about respiratory illnesses is that they are largely preventable, and it is very important for us to do our best to prevent them because they can have very serious downstream effects. Just to kind of give you a sense of how important it is for us to try to prevent them, I have some data on COVID, the flu, and RSV, which is respiratory syncytial virus. You may have heard about this from your doctors. It's another lung virus. Adults who are older than 75 in that older adult category are more likely to die from COVID, actually 9 times more than younger people in the 20 to 40 age. And over 95% of older adults who have been hospitalized for COVID in the last year had no record of receiving that last COVID vaccine. In addition to that, there are several flu-related hospitalizations, and 70% of those have recently been found to be of older adults. And then 85% of death that's related to the flu actually also happens in this age group. And finally, kind of similar numbers, up to 160,000 older adults in the US are hospitalized for RSV every year, and then up to 10,000 of them pass away. So these are kind of scary data and statistics, but essentially it shows us the importance of trying to prevent them because we do have options. So here we can see that we have vaccines for prevention. For older adults, preventing lung viruses, infections, we have 3 main vaccines. So first is related to COVID. So all older adults are recommended to get an additional updated COVID vaccine for this 2023-2024 year. Many of you may have already gotten the initial 2 COVID shots and a booster after that, but we also do recommend that you get a final booster from the most recent batch of vaccines. In addition to that, it's recommended that you get a flu vaccine every flu season, and that's usually from around September to May. So right now we're in that sweet spot of not being flu season, so the shots may not be available in your doctor's office, but just keep in mind that as we approach flu season, that's something that you should try to get, and your doctors will be encouraging you to get as well. And there are different types of flu shots. There's a standard dose, but then there's actually a high dose, and the high dose is the one that we recommend for older people because it just provides greater strengthening to the immune system. And finally, there's also a vaccine to prevent RSV. This vaccine we do recommend for most, if not all, older adults. These are sometimes able to be provided in your doctor's office, and other times we recommend for you to ask at your pharmacy. So this is something to bring up with your doctor and see where would be the best place for you to get that. We think it's really important to prevent these conditions, but we do have treatments that exist. The treatments, vaccines are in place to help prevent you from developing the condition, but actually also to hopefully make the condition less serious if you do still get any of these viruses. It's possible to get them even if you get a vaccine, but you're less likely to require hospitalization. If you do end up getting these viruses, it is possible to treat them. Here, I have 2 different treatments. First, for COVID, there are different treatments like Paxlovid. You may have heard of this or even taken it yourself. This is a pill form. So essentially, if you start developing symptoms of COVID and or you test positive for it, you want to talk to your doctor or a healthcare provider as soon as you can, because the sooner we start these medications, the more effective they are at preventing serious side effects, including decreasing your risk of needing to go to the hospital for your COVID. A lot of my patients feel concerned that they're not able to take their regular medications if they were to take this. Sometimes we have you stop certain medications, for example, for your cholesterol, just for a few days while you're taking this medication for COVID, but then you can continue afterward. And then for the flu, we have a similar medication, most commonly known as Tamiflu. That's one of the main options. And similarly, if you start developing any kind of cough, sneezing, runny nose, sore throat, those are symptoms that might make you worried about a respiratory illness that you would want to let your doctor doctor know about as soon as possible, because again, as soon as we start the medications, that makes them more effective at preventing the serious side effects. The initial part of my talk was focusing on respiratory illness in older adults, and I think that this is a really important opportunity to also talk to you about advanced care planning. This is something that you may or may not have heard about, but it's a big term that essentially just talks about communication. There are different options for your medical care. And so advanced care planning is a way that we can communicate about the wishes for the kind of medical care that you would want. And doing this in advance, meaning when you're healthy, when you're able to think about what your wishes are, when you're not in the hospital, it helps your healthcare providers, doctors like myself, and also your loved ones and family members and friends know what your wishes would be in the emergency event that you could not communicate on your own. Knowing your wishes helps providers to create an appropriate treatment plan, and it also helps your loved ones, friends, family members feel confident that they're honoring your wishes and can help reduce confusion, conflict, and guilt. Unfortunately, when I work in the hospital, I meet a lot of patients who are not able to communicate for themselves. Their loved ones are there with them, and we talk to them and say, what would mom want? What would grandma want? What would dad want? And they have an idea based on how mom, dad, grandma acted through when they were able to communicate, but they don't have a final answer. And I see that cause a lot of conflict in those family members. And so having the conversations early can prevent that from happening. And studies have also found that having these conversations early on, even if it feels a bit premature, it actually can reduce anxiety about your own health because you're able to have your own agency and have control over what happens to you, even if you're not able to communicate. So advanced care planning is the big umbrella term for just that communication. It can be as simple as a conversation with your loved ones on a regular day or in your doctor's office. Advanced directives, you may have also heard about, is a more formal term, and it refers to the written aspects of advanced care planning. So when you talk about this with your healthcare providers, they will probably ask you, who would your healthcare proxy be? We'll talk about that more in a second. And different medical orders you would or would not want. You see here the term MOLST. That is just an acronym for Medical Orders for Life-Sustaining Treatment. And this part is also known as a living will. We'll go into more detail about each of these aspects, but essentially it's important once you fill out this type of paperwork to make copies for multiple different people. First, you want to have a copy for yourself. A lot of people will choose to keep this paperwork in a place that's easily seen in the house, on the fridge, or maybe with their other documents that are important, so they can easily be accessed if the ambulance comes and those providers want to find that paperwork. You also want to give a copy to your healthcare proxy so they know what all your wishes are and they have everything updated. And you also want to make sure your doctor has a copy so that they can have it in the medical record and it can hopefully be accessed by providers throughout different states. So first, let's talk about what naming a healthcare proxy is. Healthcare proxy is another fancy term in medicine for who you would want to discuss your medical decisions with, and further than that, who you would want to appoint to communicate your healthcare decisions if you are not able to communicate on your own. So here you see an example of the beginning part of the form, and you would fill it out and say, I, for example, my name is Tatiana Riquijo, hereby appoint my mom, and then I would fill in my mom's name, her contact information, and then it says, as my healthcare agent to make any and all healthcare decisions for me, except to the extent that I state otherwise. So if you're able to communicate, the healthcare team will always ask you first, but you're always with the option to discuss it with whoever you want, including your healthcare proxy. But in the event that you are not able to communicate on your own, for example, if you're very, very sick or in a coma, which hopefully will not happen, but just in case, then they will go to your healthcare proxy that you've named and say, what would your loved one want in this situation if they could speak? Or what would they say if they were able to communicate for themselves? Then you can see in number 2 that you can also include an alternate agent. I have many patients who have more than one child, so they'll name their daughter perhaps as the main healthcare proxy, but then they'll also name their son as the alternate agent with the plan for both of those children to talk together about what their parents' wishes would be. So that was a healthcare proxy. Now we can talk about the other type of advanced directive, which is the MOLST form. Again, this is an acronym for Medical Orders for Life-Sustaining Treatment. This, you may also heard, is a living will. Here, it might be hopefully not too difficult to see, but essentially this is where you would designate what different medical treatments you might want. You can list here whether or not you would want to go to to the hospital if you were feeling very sick. If you were in the hospital, you could also designate whether or not you would want lab draws, whether or not you would want antibiotics, whether or not you would want dialysis if your kidneys needed that kind of support. So you're able to kind of list out what different treatments. A lot of patients will say, try the different treatments that are available, but then if things don't seem to be helping me, then maybe things might change course. And that's when the healthcare proxy would be important to help have those conversations. The other thing that's very important on the MOLS form is something known as your code status and sometimes referred to as resuscitation orders. You might see that in the top part, that's section A, and we'll talk about that in a second. So code status is something that you can designate on your medical orders for life-sustaining treatment form. This might also be called resuscitation orders. It's possible that you may or may not have heard of this, and it is a difficult conversation, but in my practice, I'm hoping to make it less of a difficult conversation because to me, it's important for all of us to think about the different medical treatments we would want and be confident enough to communicate that with our providers, with our loved ones, so that we can have our wishes honored until the very end. This is a little bit more applicable when people are in the hospital because it essentially refers to when your heart stops. Most people will pass away naturally at home and their heart will stop. Some people get very sick and they are brought into the hospital, and it sometimes comes to a point where their illness is so critical that their heart is not able to beat effectively to pump blood to all the organs. In that case, there exists an option that's called CPR, stands for cardiopulmonary resuscitation, or it's also called chest compressions, where essentially healthcare providers can push very forcefully on someone's chest to try to pump blood throughout the body when the heart is no longer doing so effectively on its own. There's also an option to provide electric shocks to try to help the heart beat properly again. That's essentially what CPR refers to. Then the other option or the other instance that might happen is the need for intubation and mechanical ventilation. These are big words, but they essentially refer to when the body is not able to get enough oxygen on its own. And so a tube is needed to be placed down someone's airway into their mouth, into their throat, and then connected to a ventilator that will then breathe for them. So these are different options that are there if someone becomes very critically ill, that their heart and their lungs are not able to work on their own. But it's important to know that CPR and intubation and ventilation don't always lead to survival or recovery. In general, the chances of someone surviving CPR are about 1 in 7, and some people are willing to go through all the different medical treatments and being on a ventilator to get that chance. But other of my patients say if the chance is that low, I would not be willing to go through that. So overall, it's just important to think about what choice is best for you in terms of how you want to spend the rest of your days. So in summary, we talked about a few different things today. The first is that older adults are those who are 65 and older. They are at higher risk for respiratory illnesses like COVID, the flu, and RSV. These can and should be prevented with vaccines. And then we also talked about advanced care planning, which is essentially communicating with your loved ones and with your healthcare providers about what medical care you would like to receive. So I really encourage all of you and empower all of you to think about who you would want as your healthcare proxy to speak for you if you were not able to communicate your wishes on your own, and what your code status preferences might be.
If you do qualify for that additional boost, how long does it have to be since you got your last booster? Just so we make sure we're getting the timing right.
Can be within the last 6 months. I know that if you had a recent COVID infection, you have to wait at least 3 months before you get a new booster, but we usually encourage to get it as soon as that time happens to prevent another infection.
So if you designate a proxy, does that apply to all hospitals and clinics that you would go to, or do you just share that information with them and then it will apply across the board?
Yes, you can essentially communicate with your hospital team that you have appointed a healthcare proxy. They may not have the physical forms in their electronic medical record, but that's why I encourage people to always have their own forms and say, I have filled this out. Otherwise, if you don't have it with you, that's also okay. Your team will ask you to fill out a new form. And I also wanted to add that these decisions are fluid. You designate them on the form, but if you decide that you would like to have a different agent, you can always complete a new one. So you don't have to feel bound just to that person.
It's not a decision you make once and then you're locked into.
What ends up happening is you have a witness. That's why it's usually completed in a doctor's office or in a healthcare setting, and you have two different witnesses.
Is the person you're married to technically your proxy? I mean, do you need to do proxy documentation for your spouse, or is that sort of assumed?
The answer is kind of yes and no. So when you are
Okay.
married, there's kind of like a chain of command, for lack of a better term,
Sure.
where if you're married, your spouse is the person that everyone would turn to for the decision making. But we still do encourage you to fill out a healthcare proxy form so that it's loud and clear. Also, some people who are married choose to have other people as their healthcare proxies, for example, their child, their friend, someone who knows them. Essentially, you want to appoint the person who knows you the best and will do their best to carry out your goals and wishes when you're not able to communicate on your own.
All of these decisions, including code status, everything is very fluid. Very important to think about just being prepared for things.
It's a really good way to make sure too that you've had that conversation with people beforehand, sort of reducing stress for the family members that would have to make those choices. That's a big deal. And I think a lot of us would want to make sure that making those decisions is as easy for our family members as possible.